This is our reception and consulting room area where we receive minor burns patients, and there are dressing rooms where we treat them. But the major burns patients come from other area to directly to this casualty area where we resuscitate the patient and then shift to this ICU, which is 10-bedded ICU. And there are specially trained staff nurses and RMOs here. And each cubicle is separate and provided with all the facilities like central oxygen, central suction, ventilatory management, and various types of monitors, IBP. Even we have a facility for dialysis in each of the cubicles. And when patient is stable, then there is another 10-bed burn section. We can shift the patient at that step-down burns unit. And this is the dedicated burns operation theater having all the facilities of best of anesthesia machine, monitors, etc. This is a 100-bed hospital. It is NABH accredited, and the operation theater is class 1000 laminar flow unit. These are the machines specially needed for burns care. Like this is Meek microwatting machine, and this is dermatome, and these are measures for expansion of the skin graft. This Meek microwatting can help for expansion of the skin for large surface area burns. And these are anesthesia and monitoring equipments needed for perioperative monitoring. That is, this is a FABS anesthesia machine, warmer, then IBP and ETCO2 monitors, and video laryngoscopes. Then for those patients needing ventilatory management, we have both NIV, non-invasive as well as invasive monitor systems. And these are additional equipments like silicone tourniquets, feeding pump, fluid warmers, blood warmer, and then NPWT machines, DVT pumps, air mattresses, etc. Coming to next, that is our big passionate team. We have 75 to 80 staff with us. As you all know, burns needs a big team. Admission criteria is standard for pediatric burn 10%, adult 20%, and special areas of burns, electric, chemical burns. For the process of receiving patients, first we receive the patient in casualty area. We put CVP lines. If needed, fasciotomies are done. Patient is stabilized and shifted to the ICU. We have segregation of critical and very critical patients. Then, if in case of mass casualty, we shift the patient directly to the ICU. Fluid protocol, we follow standard Parkland formula. Albumin or FFP is given if needed for after 24 hours. On admission, we start RT feeding soon, and we see to that we are not overhydrating the patient. Pain control is given round the clock. And then regarding dressing, we clean the dressing with NS and betadine scrubbing solution. And after 24 to 48 hours, we take the patient in operation theater, thoroughly clean. If the burns are second degree deep, then we put silver dressing. If patient is affording collagen dressing, and if patient is having third degree or deep burns, we pose the patient for tangential excision and immediate grafting. If all the other criteria are fulfilled, like patient is stable, there are no comorbidities, parameters are near normal, like that. And those patients needing silver dressings, that is deep secondary burns, we manage them with silver dressings. This is collagen dressing for superficial secondary burns. Coming to infection control SOPs, microbiologist is the head of our committee, and he takes regular rounds and he trains the staff, and antibiotic stewardship is followed. We do culture sensitivity regularly, and even microbiological surveillance is done for all the areas like burns, OT, ICU, emergency rooms, etc. At the time of discharge, we educate the patient, give psychological support. Coming to USP, mainly USP is our dedicated consultant, passionate consultant, surgeon, anesthesiologist, intensivist, chest physician, pediatricians, and especially myself and my wife anesthesiologist, we stay in the same building in the top floor, so we can reach to the patient anytime if needed within 5 to 10 minutes. So there is a close monitoring, and if needed, we can do earliest intervention. This is our USP. Another USP is trained dedicated staff working with me since last 22 years, and who is regularly updated and trained. Also, we have the most advanced machines, protocols, and experience of last 22 years. regarding patient care. We treat around 800 to 1000 patients per year. Yes, the main USP is better results. As the length of stay and survival is improved at a hospital, we can give affordable and cost-effective burns care to the patient. Hence, we are popular. Also, we have social impact through media. We do public awareness and education of the public. So, trust of the patient and relatives is the main USP, I can say. And we can proudly say that my house is your house, that is, mi casa is tu casa to the patient. So that patient will have confidence on us and will have psychological support to the patient. This is our great team. I thank you for the patient here. Thank you.